Hello again. I will now talk about immunosuppression and some risks in organ transplantation. And this, of course, is more in my comfort zone. Regarding immunosuppressive therapy, I think there is no basic difference in the need of immunosuppression between different organs. So if it works for kidneys, it will most probably work in livers and hearts. So this is the bearing principle. Although, having said that, there are the organs differs a little bit in antigenicity. So you might not get away with using the same drugs in all organs. Most immunosuppressive protocols are not based on controlled trials. They are based on traditions, trial and error, maybe emotions, or theoretical considerations. But the last 5 years, there are several randomized controlled trials which give you guidance on what kind of principles you should go at, and this is what we will discuss today. Immunosuppressive therapy will lead to some consequences, naturally. There are acute and chronic toxicity that you have to bear in mind. And maybe the most important of these with the modern protocols used today is the nephrotoxicity. You have to take into account infections, and these are mainly close to the transplantation. So if you have rejections, you will have to give more immunosuppressions, and you will have a higher likelihood of getting infections. So they all are connected. Malignancies, for people that are not familiar with transplantation, malignancy sounds, of course, very dangerous. You should, though, know that we are talking mainly about skin malignancies, and this is after long-term use of immunosuppression. You could, if you have a patient with a lot of rejections and you have to treat, you can get a certain kind of lymphoma called PTLD, or post-transplant lymphoproliferative disorder. This is also usually after heavy immunosuppression, and it will not be likely in the event of a uterus transplant because of reasons that I come to. Then, of course, rejection. And for those that are not familiar with transplantation, this sounds very dangerous, of course. But I can assure you that it's not this fierce. Rejection is, I think, a physiological reaction and will probably be present in all organ transplantations to some degree. But it will not be a significant clinical problem in most of the patients. You have to have some kind of monitoring, though, because if you don't recognize the rejection, it will be a clinical problem. Other risks that we have to take into account that we meet in any organ transplant, of course, is the technical problems, which are usually close to the procedure. This, like in any other surgical procedure, would be bleedings, and since the patient will be very observed. Usually after the procedure, this is usually not a big problem and should not be a problem in uterus transplants. And unless you have an unusual coagulation profile, meaning that you have something, you're on dialysis or you have a liver failure or some kind, this is not a problem. You will have a risk of anastomotic insufficiency. That goes for maybe the most obvious is for vessels, causing bleedings, but it can also be other hollow organs if you include those. So in the uterus, that would be problems with the vaginal anastomosis, for example, and the vessels. Strictures, we meet those in vessels. You have to be very careful with the vascular anastomosis, because if you have an outflow problem on the vein side, that will cause a problem. And at the same time, if you do the arterial anastomosis, it has also to be done meticulously. So we use loops to minimize the risk of doing a too tight anastomosis. And of course, the same goes for other anastomosis in the uterus. That would be the vaginal anastomosis also, because that's the only other anastomosis we perform. You could, of course, have wound infections, which will be more common in transplanted patients, since you have immunosuppression, so you have to include prophylactic antibiotic, which is part of the protocol. And this list, you can see that there is a menu of drugs that most of you probably have not been across. You know about prednisolone, of course, but then the other names here are usually not common in your specialty. And I don't want to bore you with all of them, but I think you should be aware of some of them. Usually side effects are dose limiting factors. The more you give, the more problems you will have. And this has been known since the late 50s, early 60s, and therefore most immunosuppressive protocols today are a combination of several drugs to try to lower the doses, and in that way we will not have so many side effects, but we will achieve maybe a synergism between the drugs also. So we should maybe talk about regimens rather than individual drugs. But to be able to discover side effects and to know which drug is causing the problems, you have to know a little bit about what side effects you can have. And if you, so that's a good thing to have a transplant surgeon in the team, because if you read the label and the side effects, you will get really scared, because it's several pages for each drug. But acute rejections are most common the first 3 months after any organ transplantation. So this is a problem close to the transplantation. And therefore, usually the regimens may differ close to the transplantations versus after a long run, after the maintenance. One of these drugs are steroids, prednisone. Usually they are included in most regimens since the 1960s. You remember we started with the steroids. The first attempts to do kidney transplants, allogeneic kidney transplants in humans, included steroids with very poor results, but still there was a few patients that survived. It's used for anti-rejection therapy, usually intravenously as bolus doses, but you could also use very high doses given orally. It's inexpensive. You use maintenance doses, usually around 5 to 10 milligrams per day. The problems, you all know about the Cushing habitus, and if you look at the early transplant experiences, the patients were very marked by the side effects. You can acquire diabetes. You can acquire a vascular bone necrosis, and many of these patients early on in the early series with kidney transplants actually had to have hip replacements because of problems with the joints due to the high doses of steroids. You had growth retardation, very frequently seen in children transplanted with kidneys. They were short, they were looking awful mainly due to steroids. Of course, you got gastrointestinal problems, ulcers, bowel perforations, and one of the prophylactic drugs we give to uterus transplants are ulcer prophylaxis. So that's one of the reasons. You can also get psychological or psychiatric problems due to this drug. The other drug that I would mention a few words about is azathioprine. You know that was it's actually a drug that you received the Nobel Prize for. It was launched in the early 60s, late 50s at the lab of Joe Murray in Boston. Azathioprine plus prednisone actually made it possible to get a few of the kidney transplanted patients to survive. It made allogeneic organ transplantation possible. It's a purine analog, it's a cytotoxic drug, and it affects all dividing cells in the body, and usually you take the pills of between 10 to 50 milligrams, and a common dose with this drug is about 100 milligrams or 150 milligrams a day. The problem with this drug was that you could get leukopenia, and you get a bone marrow depression affecting not only white cells but also red blood cells and platelets. And this was the reason why the kidney transplants did not receive more than 10% patient survival in 1962, because the patient reacted very often with the pancytopenia, and then you lowered the dose, and then they got rejection a few days later, and then they died. You have side effects from the gastrointestinal canal. You have hair loss, pancreatitis, and so on. So this drug was not successful, and it was until cyclosporine A, the first trial came actually in 1978 by Soroy Koln, and this is a cyclic peptide, and it's you can have these in capsules up to 25, 50, and 100 milligrams. You can also give it as an oral solution, and it actually also exists as a IV solution. Cyclosporine A made results improve greatly, up to 70% 1-year survival in kidneys at that time. The problem with the drug is that it's nephrotoxic. You can get some tremor. You also get an increased hair growth, which is for women was really a big problem, and also for children. You got hypertension, you get hyperlipidemia. You could also give gingival hyperplasia, which is not a very nice side effect. And then came a similar drug. It's also what we call a CNI, called tacrolimus. It was launched in clinical practice in '96. It's a macrolide. It has an action that is very similar to cyclosporin, but it's much more effective. And you commonly take tablets or capsules in the range of 0.5 to 5 milligrams. It can be given intravenously, but I don't know of anyone using it because it's very, very toxic. The side effects here are similar to cyclosporin. You can get nephrotoxicity. It's diabetogenic in combination with steroids in a frequency 1 to 3%. Modern protocols with lower doses has reduced this to lower numbers. In high doses it can be very neurotoxic. You get less hypertension, less hyperlipidemia than in cyclosporin. You can get hair loss, but it's a more modern drug than cyclosporin. Finally, mycophenolate mofetil, or MMF, Cellcept is a common name of it. This is the sort of the new generation of azathioprine. It has been on the market since '96 and is part of many of the modern protocols today. It's also purine analog, and you typically have capsules of 250 milligrams or 500 milligrams, and a common daily dose for patients with organ transplantation is 1 to 2 grams twice daily. You have it as an IV formulation as well. The side effects of MMF is abdominal pains, and actually you can have abdominal pains. It looks like an acute abdomen, and you have to operate it. So it's a good thing to know about this. You can get gastrointestinal problems like diarrhea, constipation, and you can, just as you can with azathioprine, you can get leukopenia and pancytopenia. So you have to adjust the doses. If you get some of these side effects, you have to lower the doses. Then a few words about induction drugs. We learned through different studies that if you want to reduce the doses, you can actually induce a drug at the time of transplantation for a short period, and then it was possible to lower the doses of other immunosuppressive drugs. And one of these is basiliximab, or Simulect. It's an interleukin-2 receptor antagonist, and the IL-2 is one of the basic mechanisms in T cells that wants to attack grafts. So it really acts on the T cells. It's given in a total dose of 40 milligrams. You give 20 milligrams the day of transplantation, and then 4 days later you give another dose of 20 milligrams, and that's it. It's usually doesn't have a lot of side effects, and it's accepted by most patients. The other way to do induction is using antithymocyte globulin, and the history of this drug goes back to the mid-60s. It's very effective. It acts by killing T cells with the CD3 receptors. It's most effective if you give it as a single bolus dose around the transplantation. It can be used also as an anti-rejection therapy if you have a steroid-resistant rejection. So the protocol of choice today in modern organ transplantation usually includes some kind of induction with most commonly IL-2 antagonist or ATG. It's more common to use tacrolimus than cyclosporin as a primary immunosuppressive drug because it has, it's more effective than cyclosporin. In most protocols, still they use prednisone, but it has been shown that you can actually perform transplantation without steroids. And it's also very common that you use mycophenolate mofetil. If you use this triple drug therapy with induction, commonly you have a rejection rate of about 10 to 12%. That is patients with clinically significant rejections that you have to treat. Okay? And the success rate in treating these are almost 100%. And the 1 year graft survival in kidneys and livers today is more than 95%. So this is actually a very, very effective treatment. So when we discussed the uterus, we wanted to use a low-risk protocol. So how should that look? Because the data from animals indicated that the uterus is an organ with is not a high-risk organ to transplant. So we would use the ATG induction, we decided, and that would be as a single dose perioperatively. We would go for tacrolimus in low dose, and the low dose is 5 to 10 nanograms per mil. Usually, if you look at the label, you should use 10 to 15, and in many programs today, that is the target, but we have a lower target. We use MMF initially, but it's saponated after 6 months, and we don't use any steroids initially. If we have rejection, steroids will be given as bolus doses, and then it could be given in a low dose, either continually or saponated. So in conclusion, current immunosuppressive treatment in organ transplantation includes a combination of several drugs. This is very common. Usually it's, you use an induction agent in the majority of the protocols, and you use one of the 2 calcineurin inhibitors on the market, that's cyclosporin or tacrolimus, as the primary drug. And if you look at the total doses given today, the doses are much lower compared to when the drug was first launched, and that has minimized or reduced the side effects. Thank you.
So I would just want to point out one big difference between our immunosuppressive protocol and the Turkish one is that they use a much heavier protocol where they only give ATG for the first 7 days, and they also stay at higher levels, and they stay with triple immunosuppression after 12 months. And of course, when you start with a new organ, you don't really know what is the most suitable ones, but what we have learned from hand transplantation and face transplantation is that they started out very heavy, but after some years they understood that they could go for this more modern protocol. Do you have any comments on that?
No, I think it's wise to not give too much immunosuppression. This is a non-life-saving procedure, and you should try to minimize the damage by the medication, I think. And we've shown that you can actually get away with the monotherapy with the tacrolimus in low dose. So I think that is the right way to go.